what new and updates? Yeah, please.
Good morning, Chairman, Co-Chairman. So I'll be talking about what's new, what's the update on the medial epicondylitis. It can be found, but not as common as the lateral epicondylitis. So there are still not many studies on it. And it is a disorder that involves the origin of almost the whole common flexor pronator tendon. Initially, inflammatory process was considered to play main role in the medial epicondylitis development, but the histological analysis show that it is related to degeneration, and the pathophysiology also revealed there's angiofibroblastic hyperplasia. Even though it is known as golfer's elbow, but other sports can also lead to medial epicondylitis like bowling, weightlifting, football, and even tennis. And interestingly, 90% occur from specific jobs that require extreme motion of elbow, high repetition of elbow movement, or forceful grasping or lifting heavy objects. Those jobs, for example, carpenters, bricklayers, hammermen, painters, and typers. And there's a systemic review of literature clarifies that medial epicondylitis is associated with handling heavy objects for a long time or many times a day, or having a repetitive movements or vibrating tools for more than 2 hours a day. Also, if bending and straightening the elbows for more than 2 hours a day also contributes to the occurrence. A single traumatic event can also lead to medial epicondylitis, and other non-movement risk factors are aging, smoking, obesity, and psychological distress. Patients will come with medial elbow pain. The pain characters can be varied, but the pain will be at the muscle tendon junction or origin of the common flexor tendon. And the pain can radiate to forearm and can aggregated by performing a flexion of elbow or wrist or a forceful grasping or lifting an object. And other associated symptoms can be joint stiffness, weakness of hand and wrist, and ulnar neuropathy. When there's a tenderness about an anterior and distal to the medial condyle, and the patient might feel pain or weakness when there's a resisted wrist flexion, pronation, or forceful grasping. And there's this test I found, it's a poke test. So asking the patient to flex the elbow at 100 degrees with forearm supinated and ask him to grasp or lift about 2.5 kilograms. And the test will be considered positive if the pain develops on the medial epicondyle. The medial elbow pain can also be caused by other conditions or occur at the same time. So don't forget to look out for these diseases too. And there are other diseases that usually accompanies in these occupational patients. For investigation, plain films can be useful. About 1/4 of the cases had calcification, and X-ray can also rule out other causes. Ultrasound can be used even though a small series show high sensitivity, specificity, positive and negative predictive values, but the diagnosing accuracy is highly dependent on an operator. MRI is a standard modality for diagnosing the medial epicondylitis, and you will see an increased signal intensity at the common flexor tendon origin area. For the treatment, it's similar to lateral epicondylitis. Medial epicondylitis has been considered as a benign self-limiting disease process that improves with time. Initial management is the modification of activities and avoid movement that would cause the pain. NSAIDs can be used to reduce inflammation, and there's new study on breast in medial epicondylitis. Physical therapy can be used, but no comparative study in medial epicondylitis yet. And for injection using corticosteroid, the study shows an improvement of visual analog score at 8 weeks, but there's no long-term study was found in the medial side yet, unlike the lateral epicondyle that has many studies. And injection using platelet-rich plasma or PRP, this case series uses 2 leukocyte-rich PRP, comparing with surgery. They found no difference in functional scores, but PRP has a significant earlier time to full range of motion and pain-free status. Next, the extracorporeal shockwave therapy was also studied. It showed it was not effective in patients with chronic symptoms, but when they study in an acute onset of 1 month, they compare with the local steroid injection. Even though local steroid injection group improves more in the functional score at the first 2 weeks, but the shockwave therapy has a higher proportion of excellent functional score by final 8th week. Next, dry needling was reported in 1 case with improved outcome within 1 week. And the next one, ultrasound-guided radiofrequency ablation was used to target the medial epicondylar sensory nerve. A case report showed improved pain and functional outcome with follow-up of 1 year. Failed conservative treatment is an indication for surgical intervention. A systemic review last year showed that past 16 studies had high surgical success, high rate of return to sports and work with low complication rate. The operation that can be done are open debridement with repair, percutaneous release, arthroscopic debridement. Starting from the open debridement, this study shows open release with partial epicondylectomy and also multiple drilling to enhance the neovascularization. They also perform ulnar nerve release. They have good functional outcomes and return to work at 2.8 months and return to exercise at 4.8 months. Next, the repair concept actually started since 1995, but at that time they used VIQ. Then 20 years later, suture anchor was used for repairing with side-to-side technique. And 3 years later, new way of releasing the tendon and also new way of repairing was established. Mean time to pain-free and range of motion is about 3 months. And this technique, instead of excision in oval shape, they make a T-split and then subperiosteal elevation of flexor penetrator origin flap, and then perform epicondylectomy, and then they apply double load suture anchor. Then repair with a pants over vest fashion. Then this year, a new technique was reported. They used, instead of using 1 suture anchor, they used 2 suture anchor to expand the area that the tendon can attach to the bone. And besides open technique, in India, they performed a percutaneous release under local anesthesia. The study showed excellent outcome. An arthroscopic technique was introduced in 2017. They detached the common flexor tendon from the medial epicondyle. And another study also showed good outcome of the arthroscopic release. Then this year, there's a paper show an endoscopic release. So for the setting, it's in supine position, just like in the picture. They use the radiofrequency device to clear the surrounding fascia to expose the common flexor tendons. Then the origin tissue of the pronator teres and common flexor is debrided. And cubital tunnel retinaculum is also removed to release the ulnar nerve. With all the techniques I had been talking about, all techniques show excellent results, but no study had compared between each of these techniques yet. To summarize, so the medial epicondylitis is the common flexor predator tendon that develops angiofibroblastic hyperplasia and usually occur in occupational patients rather than in athletes, and few can obtain from the traumatic event and usually come with medial elbow pain, and there's a tender at the flexor predator origin. For imaging, plain film can be useful, but MRI is standard. And conservative treatment is the mainstay for the management. But if it fails, then surgery is considered. So a lot of further studies still needed for a better evidence-based decision on the choice of treatment. Thank you for your attention.